This is Brian Wormers recording a lecture for pediatrics on musculoskeletal system. So looking at our objectives, the first thing we're going to cover is immobilization of the child. Then we're going to go on to cover fractures and trauma. Then we'll talk about a child in a cast. We'll talk about traction. We'll talk about DDH, congenital clubfoot, osteogenesis imperfecta, leg calf-Perthes disease, and SCIFI. Then we'll talk about therapies and nursing care of a child with scoliosis. Then we'll talk about osteomyelitis. And then we'll talk about tumors, septic joints, JIA, and SLE. So immobility is very hard on kids, and the reason why is because they tend to be very active, and you can't always rationalize with them as to why they need to stay in a bed. But it really affects all of them. You know, it's going to affect the musculoskeletal with having decreased strength, decreased mobility, decreased endurance. It's going to affect the bones and the fact that you get some demineralization and calcium reabsorption, so those bones get weaker. It's going to affect the metabolism because you'll have a decreased rate, and then you're also going to have a hyper calcium level because it's been sucking out of the bones a little bit. Cardiovascular system-wise, you're going to get some venous stasis, some edema, and some distribution issues with your blood. With the respiratory system, you're going to have decreased capacity and decreased muscle strength. With the GI system, it's going to be difficult to feed. If you guys have never tried to eat while laying flat in bed, try it. It's very difficult, and to expect our patients to do that is not reasonable. Difficulties with stooling without being up and being vertical. Stooling is affected with this. And then anorexia, because they just are not hungry. They don't feel good, they're not hungry, they haven't burned enough calories to work up an appetite, and that leads into problems too with wound healing because we're not getting enough nutrition in. Integumentary system, of course, decreased circulation, and then we're worried about any kind of pressure wounds and ulcerations. Urinary system, it's difficult to pee, sometimes in a supine position, and so that's an issue. And then psychological, we can have some regression in kids, of course, because they go back to a time in which they're more comfortable, and we can have some altered perceptions, definitely some frustrations because they want to go run, jump, and climb trees like their peers, and then even some depression related to that. So here's a good picture of some of the traumatic injuries that can happen. I mean, of course, you can get it to your bones and your fever, like here. You can get strains, so the T in strain relates to a tendon. You can get some ligamental damage, which is a sprain. You can get some joint involvement, such as a dislocation, which we'll talk about here in a little bit. You can get problems on the bone, specifically at that epiphysis, and so that growth plate, and that causes lots of problems in kids. So if you fracture this and it doesn't heal right, you can get limb length discrepancies, and that can need surgical correction then. Fractures of the tibia, esophageal issues with muscle and soft tissue. Oftentimes we're talking about bruises and contusions with that. So a lot of the treatment for this is going to be RICEs. I mean, it's basic treatment of rest, ice, compress, elevate, and then support them. Dislocations, you can talk about nursemaid's elbow. You can click right here and get a good view of it. I personally love doing nursemaid's elbow. It's something that's fairly easy, but you know, you see a big difference in the kid. You get that immediate satisfaction. Lots of different fractures that we can get in kids. Considerations for this, you know, is it through the growth plate, which is always going to be more damaging to a kid? Are they at risk for breaking this again? How did this break happen? Was it accidental? Was it non-accidental trauma? You know, how did this happen? Lots of different styles here. So a closed non-displaced means that it's not shifted over. This would be an open compound fracture, so it's open and through the skin here. Comminuted means fragments. Displaced means that it's not lined up. It's like, you know, over here it's lined up. Oblique, so kind of going this way across. A spiral fraction. Spiral fracture is, you know, of course, in a spiral motion. Oftentimes we get really suspicious about this fracture with trauma and child abuse because of the twist and the motion that's required to do it. Not all these breaks are child abuse, by the way, but they've got to have a good understanding for what is happening, and with this you've got to have some kind of rotational forces that impact this child. Impacted, so I usually don't see it on the arms as much, but in the lower extremities, so jumping, and then when they are falling off of something and they land and they get compression and it goes into itself. And then very common in kids, we get green stick. And so it comes from the term of if you take a green stick, one that's not really dry, and you try and break it in half, it kind of goes like this, and then it kind of goes up, and it never really goes through. So bones heal pretty fast in kids. I mean, neonatal period, you get 2 to 3 weeks, and their bone is repaired. Adolescents, as they get a little older, you're seeing that it's taking longer and longer. Big things to consider during this is looking at those P's. So do they have pain and point of tenderness at the site? Do they have pressure or poikilothermia, which is an inability to regulate temperature? Do they have pulselessness, any color changes, any paresthesia, any paralysis? So all these things are indicative of sensory motor deficits and maybe even neuromuscular damage. So these become emergent. So we're thinking about things like compartmental syndromes with this, or vascular changes that need to be immediately looked at, otherwise you could lose that limb. Casts are quite frequent in the pediatric population. A lot of times we're using fiberglass because the plaster ones are heavier and they take longer to set, and they're just kind of a pain to deal with. So that's why a lot of people do fiberglass. Plus fiberglass comes in fun colors that you can have the kids pick. If you have some of these casts, especially like with the plaster ones, we'll call it pedaling, where you take moleskin around the outside because you can get a sharp edge where this is forming, and then you cover it with some moleskin so it doesn't cut the patient with the cast. Cast care at home, it's on page 1541, but basically keeping it dry. Don't put anything in there. Don't, people, I've seen everything from coat hangers to steak knives to try and scratch underneath that. Because when your arm is underneath there, you don't wash it frequently. You get some dead skin accumulating. You get some muscle wasting underneath there, and it can itch. Cast removal. So we use a cast cutter with that. It's not a circ saw, but it's an oscillating tool, and it causes it to break up. So it sounds really scary to kids. It's a high-pitched squeal. It's a high-pitched sound that you can hear if you click on this link. It shouldn't hurt them. It oscillates, so you could even, as a provider, I'll touch it up to my hand, and so they can see that it won't cut them. Traction, we don't see this a lot in pediatrics, quite honestly. We've really gone away from this and trying to get them more mobile. But the one thing that NCLEX loves to do is they like this Bucks traction. On page 1543, you'll see a picture of it. But basically what you've got is a boot type of a situation. And they're wearing like a boot that's Velcroed on, and it puts pressure, and you've got a weight that hangs off the side of the bed. And what you're trying to do is stretch out those bones and realign them so that they can grow. Can get cervical traction. It's not super common, but you can see the halo braces for people that have got trauma and need their neck stabilized. Basically with this one, you're wearing kind of a shoulder harness, and then you've got burr holes. So basically they put screws right into the skull to hold it in place. So what happens is you're kind of stretching off this neck, muscle fatigue, and then you get alignment of those vertebral bodies. You can do it with cervical tongs too. I haven't seen these ever in practice, but it's the same thing. You're trying to lift the head, stretch out the neck, and to realign the vertebrae. Developmental dysplasia of the hip, or DDH, happens about 1 in 100 live births. And so basically things that go wrong is that we've got a shallow acetabulum, basically meaning where that hip ball goes into the socket, and the socket just isn't deep enough to hold that in. So you can get subluxation from this, meaning that you get a dislocation of that ball coming out of that hip socket, and then you can get full dislocation. So manifestations, so what we look for in these little kids is that you get a shortened limb on one side, of course. You get restricted abduction of the hip. So abduction is taking away, like aliens abduct you, they pull you away. Adduction is, remember, as it goes towards the body and you're adding it. You can get unequal gluteal folds. So when the kid is prone, so you lay him prone on a table and you look at their butt and you see how many gluteal folds that they have. You can do oral autonomy and Barlow tests. And so basically this is taking the knees and the hips and abducting and adducting them. And with these, you're trying to find a hip click is what we're really looking for. Treatment-wise, a couple of different things that I've heard of. Double diapering, and you're just trying to support that hip. Otherwise, a Pavlik harness down below. The big thing is if this is seen, you got to work on this right away. Because the longer we wait, the more difficult it is to treat. And so, newborn to 6 months, it's not a big deal to treat. But generally, as they get older, you start to use traction and casting. And then here, it's a full-blown surgery. And it's very difficult to treat. So clubfoot is when they've got internal rotation of their feet when they come out. Basically what we do with this is called the Ponseti procedure, and it's basically serial casting. So you try and straighten those feet as much as possible, and you cast them into that position. And you do this over and over, and so they've worn this for a while, then they come back in, you cut it off, you straighten their feet a little bit more, and you're basically remolding that bone or remolding those feet using castings